I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. Our guest today is Dr. Stephen Merahn. Welcome. Yeah, good to see you as well. So, tell us a little bit about how you got into this field, how you got involved into the field of support services, healthcare for people with intellectual and developmental disabilities.
Well, it's funny, and I didn't realize this until recently, but this whole thing actually got its start when I was in medical school. I went to
That's unusual.
Well, I can't say it's been consistent all the way along, but the seed was planted back then, and I only realized it when I took my current role as medical director of Partnership Solutions, which is an umbrella organization over both a care coordination health home for individuals with IDD and a very novel demonstration product of managed care for the IDD community. I only started this job September of this year, and it brought back so much of my history in healthcare. I went to medical school at the Albert Einstein College of Medicine in the Bronx. At Einstein, in your second year of medical school, first year of medical school, you get assigned a patient. Very early on, during your basic science years. My patient was a pregnant woman with cerebral palsy. And I spent 6 months at every one of her care visits. I spent a lot of time with her family. I got to know her very well. I was there at her delivery. Unfortunately, I was still in basic science years, so I didn't get to follow her through. But knowing her and having the experience of her as my first patient ever in many ways set the foundation for so many other decisions that I made downstream. Now, fast forward 4 years, I chose to go into pediatrics. And while I was in pediatrics, I again became fascinated with what we would call it the special needs population. And whether it was kids with behavioral developmental problems or children with severe disabilities or children that we now refer to as medical complexity. Mm-hmm. In my last year of training, I spent an elective period at Blythedale Children's Hospital in Westchester County, which is a skilled long-term facility for severely disabled children. And I found a vibrancy in that community. I found that despite a child who was quadriplegic and nonverbal, that person had a very vibrant life. It just wasn't the same kind of life that I had for myself.
You know, I talk about that all the time. Quality of life is different for different people, but a different quality of life does not mean it's a lower quality of life.
That's
just different.
Exactly. So this is where, the mantra that over the years, so I left training and went to work for the New York City Health Department as a policy and program development specialist, and I led the city's effort. Well, I was one of people who led the city's effort in the first 0 to 3 early intervention program. And one of the things that came up during that time, and I didn't phrase it this way, but I meant it this way, which is diversity of ability is not disability. And we tend to equate diversity of ability with disability, but it's not true. And for example, the people I know who use wheelchairs don't look at their wheelchair as a symbol of disability. They look at their wheelchair as a symbol of ability.
Yes, that's right.
This is how I get around. And it's not like they don't spend a lot of time thinking about it, just like we don't spend a lot of time thinking about our legs. They really don't. Now, I'm not speaking on behalf of the entire community, but in general, when we see somebody who uses a wheelchair, that's not a moment of compassion. They just happen to use a wheelchair for mobility.
Different way.
So don't associate that with disability. Now, by the way, if there's no curb cuts, then we've imposed a disability on them. If there's no way for them to be accommodated in a restaurant or at a concert hall, then we've imposed a disability on them. But the lack of the use of a mobility device does not necessarily mean they're disabled.
So, first of all, couldn't agree with you more. I love that. Makes perfect sense. It speaks to what we call, the kind of the social model, maybe, of supports and services for people with intellectual and developmental disabilities, and looking at how we can adapt the environment. Sometimes we hear, as physicians, we're both physicians, sometimes we hear that we're too much about medicine, or when we talk about medical care for people with disabilities, it gets kind of talked about as the medical model. Can you tell us a little bit about maybe what the medical model kind of means, but then also about your perspective on healthcare, and is that really the medical model?
Yeah, I mean, I think addressing someone's health issues doesn't mean you're medicalizing them. Addressing someone's health issues means you're removing additional barriers from their ability to participate fully as members of family and community.
Thank you for saying that.
I will tell you, I wrote a book 2 years ago, and the book talks about health as a social imperative. But the outcomes model for all of us has to be: can we succeed in the world on our own terms, and can we participate as active, and when I say active, I mean emotionally, socially, or even economically, members of family and community. And everybody's got their own level that means.
Right.
We can't impose what we mean, but for someone to have health-related risk factors when they have other risk factors in the environment means we're just adding to their burden. So just because we're going to have a plan of care that addresses healthcare issues doesn't mean we're medicalizing someone. It means we're trying to remove additional barriers from them succeeding in the world on their own terms and participating as members of family and community.
I love that. That's a great way to explain it, because we hear, if you start talking about medical care for people with IDD, it's like, oh, that's the medical model. We don't want to do that. And that's not the medical model. And what people are saying when they mean that, or when they say medical model, what they're really talking about is an outdated way of looking at a person with a disability as having something that we should fix or needs to be fixed.
That's correct.
Rather than recognizing that maybe, the world around us needs to change to support people of any ability in any way whatsoever.
Well, I will say our profession tends to be a little reductionist. And if you're trying to evolve the model of care to something more person-centered, the tendency of medicine to reduce the problem to a cellular or a molecular level does work against us. We've established,
Sure.
Let's say if there's a bias,
Sure.
That's a bias against physicians I can respect, but it's up to, again, and working now where I am, I'm the only physician with an entire organization of advocates and care managers and people who come out of, years in government and in government advocacy. The CEO of our company is the former commissioner of the Office of People with Developmental Disabilities for the state of New York. Doesn't come from the business world at all.
Right.
So I'm come to understand that so much of what we do in medicine is sometimes, I don't want to say conflicts, but there's a contrast to the kind of the bigger person-centered model. And I think it's time for both sides of that equation, the disability provider side and the healthcare provider side. Even, by the way, the word provider can mean two different things depending on who you're talking to.
I had to figure that out. For me, provider always meant a healthcare
professional, right?
You come into this field and you hear provider, I'm like, wow, there's a lot of doctors in this field. No, it's not what they're talking about.
Provider agencies. Right. So the fact is, both. If we really want to create an integrated model, it's time for both of us to sit down and say, okay, what can we each contribute to our person-centered goals? And some of that's going to be health-related, some of it's going to be social, some of it's going to be community, some of it's going to be spiritual.
Yep, exactly right. So you mentioned where you work now. So tell us where you work now and what do you do and what does the organization do?
So Care Design New York is a New York State-funded care coordination organization and health home. We're the eastern corridor of the state. About 28,000 members get their care coordination services through the Care Design platform. There's another organization that's affiliated called Partners Health Plan. Partners Health Plan is a demonstration project to examine the value and power of a managed care model for the IDD community, exclusively IDD members of our health plan. It's dual eligible, so Medicare, Medicaid, and it's actually a three-way contract between the Federal Centers for Medicaid and Medicare Management, the New York State Department of Health, and the New York State Office of People with Developmental Disabilities.
So how is that going? How is that?
I have to say, I've worked for two traditional insurance companies, not as an insurance company medical doctor. I worked for affiliated companies within those organizations. And I think that the managed care model has not done itself a service by focusing largely on the economic value of healthcare. Right now, I think, unfortunately, value-based care is very much grounded in economics. It's quality measures that support the actuarial needs of a population, not necessarily people's individual needs. Our health plan is a nonprofit organization. It's run by advocates. It's really designed as, I'll tell you, I'm actually advocating for longer length of stays as a health plan for many of our members, because what we've discovered is someone who's discharged with sepsis to a group home or facility, may be harder to get them that post-discharge care. I'd rather them stay in the hospital an extra day.
Sure.
So our focus is really on improving resource utilization to people who really, really need it. We also cover the entire spectrum of services. So we do residential and vocational and community-based services and social needs as well as part of our health plan. Non-traditional model. I personally think this is really to the benefit of the community by taking a population health approach to IDD. Think about this. Imagine taking the triple aim model and applying triple aim to the IDD community.
So triple aim is
improving the care, improving the health of the individual, improving health of the community, and managing resource utilization for efficiency. And I say that specifically because it's not about cost savings, it's about cost allocation. I'd rather say to somebody who's going to the emergency room for care that could be cared for in a primary care relationship, you don't need to go to the ED. You can go to a primary care relationship. That money gets saved.
You're going to have better outcomes.
And you're going to have better outcomes. But that money, again, as a nonprofit health plan, that money gets reapplied to other people of need. So it's really about managing resource utilization for kind of effectiveness as opposed to simply trying to save money.
So is this model going to be something you think you're going to see expanded?
I would love to see it expanded. I think, again, there are some members of the IDD community who don't necessarily they want a higher level of freedom, and they believe that the freedom of choice associated with fee-for-service medicine is better for them. I can't necessarily disagree. I can say the data doesn't necessarily agree with them.
Sure.
In-network care, when you've got a community of providers, both IDD providers and medical providers, who are committed and understand the complexities of a population, those people do much better in the long term. I was the chief medical officer of a national home-based primary care practice that took care of homebound elderly, people who met CMS criteria for being homebound. A significant amount of neurologic impairment, a lot of disability, a lot of frailty. And we were able to show in that model that when a set of providers provides 75% or more of care, meaning it's not just anybody, but it's a narrow set of providers who collaborate, provide 75% or more care, those people's outcomes are dramatically better.
And I would think in this case, the providers who have some training and experience in this field would be great.
Yeah, there is no doubt.
It can be a challenge, though, can it?
Well, it can. And I know you and I actually agree. We haven't discussed this, but I know you and I both are very supportive of the National Council of Disabilities effort to make the IDD community a health disparities population. And I think that really goes a long way. Again, back to my experience with homebound seniors, we would go to a health plan and say, how many homebound seniors do you have? And they would go, we don't know, because it's not a system level metric that they're asked to manage. So we would then do an analysis with them. How many people haven't seen the doctor in a year? And from that group, we would then identify the subgroup. And then we'd say, you know what? Give them to us. We'll take care of them. We'll sign a special agreement with you, and we'll take special care of them. We'll go and risk a little bit as well. And inevitably, those health plans were like, okay, great. We've got somebody covering them, because the risk of somebody who's not getting care showing up in the emergency room and having an extended stay because they're underserved for over a year is quite significant.
So earlier you mentioned you wrote a book.
Yes.
All right. What's the title of the book, and talk about it?
Okay. Well, the title of the book is Care Evolution. It's a series of essays on health as a social imperative. And what that means is, just like we have an imperative in society, we collectively have decided we have a social imperative to education. There's K through 12 mandatory education in every state of the union. Whether you agree with the nature of that system or not doesn't matter. We have collectively decided there needs to be a social investment in literacy and numeracy. We've done the same thing with law enforcement. We have a collective agreement that law enforcement is a social imperative. Again, you can disagree or agree with the way law enforcement is is managed and operated, but the fact is we've made this social imperative. We do not have a similar social imperative for the health of our population. And in fact, there are people who will argue whether we need to be investing in the health of the population. I genuinely believe that it is in the best interest of us socially for people to be healthy. And you know what? It has nothing to do with individual lives. Actually, it has to do with the economic vitality of our communities. The more people who can work will work. The more people who can be productive will be productive. The more people that can go and participate in community activities, the more vibrant our communities are.
And all of those things relate to your health.
All those things relate to your
Yes.
health.
You can't do many of those things very well if you're healthy.
So if we have, swaths of our country with preventable illness, we're doing a disservice to our nation socially and economically by allowing those people to continue to have preventable illness.
How do we fix it?
Well, to tell you the truth,
In 2 minutes, how do we fix it? No.
so I'm going to bring it full circle back to the conversation you and I were having about, there's two provider communities that work with the IDD community. There's the disability providers and the healthcare professional providers. Orchestrating the care between those two groups around a single source of truth for what the patient's care plan is critically important for that. If I know, for example, that there's an aspect of someone's care plan that is about them becoming employed, and I as a physician can do something to reduce any barriers to their employment, I will then contribute that to the care plan. It doesn't have to be based on a diagnosis. It can be upon my role as a physician. I can look at somebody and say, oh, there's some functional limitations that I can help intervene and improve, and therefore this person is more likely to be employed. Same thing's true on the social economics of the social imperative. It's not about how we pay for care. It's how we care. It's how we develop care plans. It's how we collaborate around those care plans. It's how we orchestrate all of the resources that can influence the variables of someone's health. In medicine, we chose years ago to adopt the SOAP note, right?
Gosh, I don't practice anymore. I forgot about the SOAP note.
Let's just
I sure have used it.
Let's just realize no one told us to do the SOAP note. There were no regulatory environments around the SOAP note. There was no legislation or CMS regulation around the SOAP note. We, as a professional community, decided to do something.
So everybody listening, though, we just have to explain that for a second. A SOAP note, SOAP, stands for Subjective, Objective Assessment and Plan. So it's just a kind of a way to document.
It's a consistent framework for all of us to write a note that can then be understood by anyone walking in behind us. You'd use the SOAP format. I can share you my SOAP note. You'll know what that means instantly. Yep. Now we can communicate better. And there's an architecture to a progress note.
Yep.
Well, again, that was not imposed by any regulatory authority. We didn't get CMS to say anything. We didn't do research. We actually did a little research. But the fact of the matter is, as a professional community, we chose to adopt a standard of practice. We have that choice available to us at any point in time.
And it's better to choose to do it. I would think that have to be regulated to do it. Right?
And we're not talking about anything that involves reimbursement. We're just talking about a way we work. The coding and billing stays exactly the same. But if we choose to create a care plan framework that is universal for the patient, if we choose to share our care plans with other people who were involved in that person's care, now we can begin to orchestrate care. And this, by the way, is a big chunk of the book. Now, I just want to say one quick story about the book. So the book got started because I wrote another book. I wrote a book on population health. I've been going around the country for a long time. I ran an ACO. I know a lot about kind of the operating model for pop health. Not important right now. No, seriously. So I in 2019, I took most of the year. I wrote the book. I had been working on it for years. And December of 2019, the book was finished at a publisher, and we were getting ready to go to market. And then March 2020, COVID hit, and the book meant nothing. The book was over. You can't launch a book in the middle of a pandemic that doesn't mention the pandemic and talks about this obscure pop health stuff. So I'm on the phone with my publisher, and I'm kind of ranting about this whole thing. And he says, hang on a second, and puts me on hold, and then comes back, goes, okay, keep going. So I finished my rant, and he goes, look, we'll talk about this next week. We'll figure out what to do with the book. 2 days later, I get an email from him with a PDF. He had recorded and transcribed my rant. And he goes, this is your new book. He goes, we're going to do a couple more of these, and we did. He goes, and then you're on your own. And that's why it's a book of essays now. It's not a narrative.
So where can we get the book?
You get the book on Amazon?
Yeah.
Yeah.
Sounds like an interesting read for sure. You are a man full of fantastic first experiences, but ideas, and truly a visionary, and it's very, very exciting.
Friends for Life Residential Care, specializing in support for individuals with developmental disabilities, offers services like adult day support and home health care. Emphasizing empowerment and quality of life, we live by the motto, my ability is stronger than my disability. We are currently hiring, welcoming those passionate about making a difference. Learn more and explore career opportunities at friendsforliferc.com.
I'm Dr. Craig Escude, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisks.com to learn more about how you can employ these tools with people you support. What are, say, 3 things you can mention off the top of your head to listeners out here that they can, be involved in, work in, do with, participate in, that you think can improve healthcare in general, especially for people with intellectual and developmental disabilities?
I'm going to go back to the statement I made earlier, which is really, and you liked it, diversity of ability is not disability.
Yes.
And if you can keep that in mind, and it's particularly true, by the way, for neurodiversity. I do a lot of work in the autism community, and there's a tremendous variation in the level of diversity, neurodiversity within the autism community. The more that we can, I don't even want to say acceptance, it's inclusion. It's inclusion, because it's back to that idea that somebody may view the world differently than you do. And when they do that, you need to rethink the fact that you need to hear their perspective more than you need to protect yourself from their perspective.
Or tell them yours.
My son is 17, he's colorblind. And when his sister was 6, this was 6 years ago, over dinner one night, she said, I wish that I was colorblind too. And of course, my wife and I looked at each other and said, well, why?
Yeah.
She goes, because then I'd be able to see the world the way my brother does.
Wow.
And I'm like, that's really cool.
Yeah, that is.
That is very cool. The only other thing I would say is there's a wonderful paper that was written by one of my professors in medical school, Ruth Stein. She wrote in 82 and 86, so this is a while ago, but stuff that still sits very well today. She wrote about what's called a non-categorical approach to chronic illness, meaning that whether you have sickle cell disease or asthma or epilepsy or diabetes, there's more in common in terms of the chronicity factor of those conditions than the biological condition of each. And again, back to the fact that we in medicine tend to be reductionist. Sickle cell disease, genetic defect, changes in the morphology,
right.
But no, the fact is the chronic nature of those conditions and the living with chronicity as a factor in and of itself actually creates more challenges from a life course perspective than the conditions themselves sometimes. So to remember the idea that, again, this is not about condition, this is about people's life course. And if you're thinking about what you do in the context of where you want their lives to go, you'll make a better contribution.
That is wonderful. Steve, I can't thank you enough for sharing your insights with us, the information, for being part of the podcast, and for the work that you do in this field.
Thank you.